In practice then, yeah.
Oh, yeah, that's right.
August, September, yeah. Then I'm stuck. Can't do a lot less conferences. And
I think the invitations have already gone out.
huh?
For the Alaska meeting?
Yeah.
Yeah, they're already out.
Review my slides.
The big thing is that she's got to get those seats as fast as she can, so she checks into the down.
What do you guys talk about?
Huh?
Did you tell her though?
One's a
That she doesn't have
need for surgery,
Told her what her
polyp and eosinophilic, or rhinosinusitis nasal polyps using IV mechanism. And then another one is
for him. You don't
restylizumab versus mepolizumab in severe asthma. So looking at IV weight adjusted to fixed sub-Q dosing in that subset of 10 patients with really severe disease.
Yeah.
So
What do you do when you, what do they do for you when you have mild?
Everything's free.
Yeah. Not bad.
How far are you? I'm MBChB too.
I'm about 700,000.
Wow.
Who's a million?
I'm 1,200,000 in Alaska, 1,400,000.
Those 200,000, you don't need those. I'm just joking. Do you get,
1,400,000.
is there anything before, after a million?
Yeah, actually, I can't imagine who those people are. I mean, they
I'm
must
not
just
sure
live.
I'm not sure I want to.
That's what I'm saying. Exactly. Anything else I can help you with, sir?
I think we're good.
Okay. I saw Wendy yesterday. Things
I got to
seem-
do something.
Is it like
Girl
flight
cold
17?
urgent care. She's responded beautifully with the one injection I gave her. She went up skiing for 4 hours.
Yeah.
Her mother put an
I
ice cube on
on
her arm.
Sunday.
She didn't react.
Wow.
But I don't think one injection is going to help.
No, it'll wear off. Did Connie call you on that?
She called me, she sent me an email with references. And I gave the references to
I mean,
Wendy. I also gave them
in
to
LA and Orange County, yes.
Megan.
I think I'm on that same flight.
And
Yeah,
I
I'll
also
go with you.
talked
It's
to
possible, but you're also competing, like
Oh,
I
I
was
talked to
competing against
Oh, okay.
probably
And I
10
said,
or 12 fellows graduating down there.
So I need to get a second.
And I would say maybe there's 2 to 3 jobs, probably like 2
Oh,
to
good.
3, 4 jobs max that come up.
Guarantee the mother will get a second.
Yeah, so I definitely think there's more fellows graduating in that area than there are
Oh, yeah, I have
jobs.
a meeting at 8 o'clock. Oh,
check
yeah,
that
yeah.
out.
Maybe not everyone wants to stay there, but
Sometimes
Oh,
we
good.
do.
at least for
Can't guarantee it.
publicly posted jobs, the Kaiser one was the only Kaiser one there besides Bakersfield for full time. And then outside of that, I know Children's LA had an academic position that one of my friends is going to sign for. And then there were like 2 or 3, I think, smaller private practices that I saw job postings throughout the year. And I don't really. I reached out to one like smaller like practice with like 3 or 4 people in Torrance, but I didn't hear back.
Yeah,
I
why
gave my
not?
CV.
There's a limited amount of it. And
there was another
a piece that
Are you starting to think about that?
the great vista of bioreference, those kind of things. So they're even more rare. So,
Yeah.
So anyway,
The problem is it's so saturated down there.
fill it out.
You're relying on
Stay
people to
clinical
retire.
sensitive. Fill everything out. And
There isn't
notes,
much that
note
like
exactly what
happens
you're telling
growth
me.
Yeah,
wise
that's
because there's
How
more
effective
people.
it is and everything else.
Yeah. Yeah. No, it's fine. All right. Well, let me know when if you need anything. Okay.
You do your
Yeah.
appeal.
Thanks.
If that appeal gets denied, then we sometimes consider that patient uninsured, and we'll put them in the GATCF.
He's going to be with us.
And if you want me to work you through the process, I'll do that.
But, any
well,
of the
was
fellows,
Wendy
second years?
I've told her, but I mean, she's getting hands busy all the time, taking all these patients in from.
I'm not working today. I'll go over there and see.
Yeah.
Haven't arrived yet.
And if you need me, call me. Yeah, I'll come. Hey,
Good
I
morning.
understand that you're
Thanks.
presenting something.
Yeah, we have GSK training.
Things good?
Oh, yeah, I got an email about that. Is he gonna sit in here?
Yeah, you can fine.
What do you mean?
Just introduce him.
Finishing.
Okay, for the
You
next.
know him
presentation.
personally? No, I've
No,
not
end of
just
March.
been to dinner. I think we
But
can
it's-
do
it's
that.
fine.
I have
I don't
biopsy.
Oh, yeah.
know who he is.
God.
Sure.
Will you
My
know
derm
him when
tells,
he's here?
says I
Will
got
you
the curves,
recognize him?
blonde hair, blue eyes.
Not here
Like
now,
skin.
I know everybody in the room.
And every time I see her,
Yeah, I'm sure.
they swear to
Yeah, I
God,
got his
she's
picture from,
she's got.
It's funny, well, not funny, but I was reading the other day and it was some app.
yeah,
And
you
it was
just
like,
come up
describe
and
yourself.
Thank him for
And
joining
one of
us
the
and now
things
get
that
the session started.
is he seemed type. I'd never heard of this.
No, he's here.
I think we'll go.
Is that it?
That's your final faculty as far as.
No, she said I got the curves,
Yeah,
that's
in
all
other
she
words, it's
says.
like always burns. Occasionally burns.
connected to the
Rarely
Doesn't
burns.
need to be
Never burns.
connected.
Yeah, benefit. I was like, okay.
Yeah. So if you're actually
Not sure why I
redheaded,
was important to the app.
yeah, if you're redheaded, I'm
Yes,
sure
yes.
you're out.
Barter, we need to get in time for.
Oh, do you need anything?
All of us on our
Okay.
might need it
Um, You don't need.
Oh, you got an iPhone?
We want to maximize the time here, honestly. It was interesting to do actually meeting.
More time
Yeah,
to do the notes.
I think if
Tom
you-
Fleischer from NIH was
if you could
counting
stumble
here again. I guess he's having a session in March.
in the character there is enough to get you to hire. So the point is, I can think of other nurses that like Shannon and stuff.
Okay, it was probably. Yeah.
You know what I mean?
I know exactly
It's
what you
that
mean.
thing, it's this feeling of I go in there is kind of how I would do it, and you
I thought I was so crafty.
because I'd read those.
Well, that's what they
Yeah,
said.
no, I almost that.
Right, yeah, and that's exactly what David said. He said that in the evening. And then he says, on top of that, I got to get somebody. The patient
No,
to pay for this.
yes, yeah,
And he goes, all of a sudden my days are busy.
yeah, I know.
No, we missed it. We had symphony tickets and all. When we started midnight, we had to return.
Oh, yeah, no, it was exciting. I didn't go there. I wanted to go, but you know what?
Oh, powwow.
So I was surprised on that.
We had just, well, we gave up this.
I know,
one.
because I thought that you
The best
but yeah.
college basketball game.
Yeah,
So what a finish that was.
I mean,
Did you watch the Huskies game? Did you hear about it?
yesterday I told you. Reading.
Did you see it? The Huskies
1
game?
hour.
That's right, you didn't go to UW.
Oh, I have a question. Did you own
Oh, you did medical school. Anyhow, a buzzer being against the good. Oh, I steal your, did I?
They just emailed me. It wasn't something like that. Did you guys get posters there?
I got a poster, but the website doesn't say anything about funding or anything.
Yeah. So we just have to wait in here. I'll ask.
Yeah, I know.
I emailed them.
Is she that trip?
Why didn't you know
I saw it, yeah, and it's a freight trip, but two things.
Because I emailed it to her.
Oh,
Yeah, you're right.
a lot of times.
Like,
30
it's
slices.
sort of
Yeah.
like-
It's, you know, I've never been there, so
How do you compare?
I know.
No, you know what I mean.
Yeah, well, I know.
So they're over there all the time fixing
But
it
that's
up.
holy crap.
He does it, he fixes it up, big
So that- that's just gotta get
It's
started.
who else then it was
So
get on.
anyhow, so we got a place to stay.
Yeah.
But, so,
And
I thought that
the
trade
logical thing
Oh,
is,
yeah.
I don't have this light on the,
allergies drive
is it still reading?
no, it sounds great. So, you know, in South America.
and I think obviously we've had well, it is.
Oh, and we know that.
You went there 2 years ago?
No, I haven't been there. So we've been to
Then you don't need to.
Yeah, sorry. No problem. No. Figured I'd
Ready
go.
now?
So it's
You know how, I mean, I would have a couple of rough days, it wouldn't be fun.
Yeah, that is true.
it's always been a question for many years.
You can handle
Anyhow,
Used to be
I,
able
you know,
although we did
I've got
that.
this thing about playing the country, plus I got cut out of the Southern Hemisphere. That's
Yeah.
one further south. So.
Well, the, yeah.
Tomorrow you're
Let
out.
them work the waters on their
Your patients are storing in.
I know.
One woman brought her
There's nothing else.
Yeah.
should have to get
You know what? They say, well, you gotta get that. You should bring it to you. You know, they say, well, you gotta mail it. You know, you mail it in a cooler box. No EMR. No EMR.
You know, Pandora wants to.
Till you got here? Well, I know that she was thinking about either hiring or working with somebody
She
else.
approached her and married the legal contract position. I mean, that's what I get out and about and take it easy. Take you a
No,
second.
no, that'd be great.
Just hand me one. You hand me this one.
Each one.
Hand me all the same
There, when I said the travel days, and at the end, at least I want to settle for it. Perfect. God, that's too hard to use.
I want to show you you could walk right here. I couldn't get around.
Here's when you should hear this.
I didn't know to do that.
No, I did see that article. I didn't read it. I just saw the title.
Now we're going back in April again.
Sure. Before we start our journals today, it's our pleasure to introduce Professor Peter Howarth from University of Southampton. He's a medical director, consultant with GSK, and he's established the Severe Asthma Center at University of Southampton, been involved in many of the pivotal studies ongoing right now and worldwide with regard to severe asthma. We're going to be having a session with him right after this, the faculty and fellows, and anyone else who'd like to join us. We're going to be learning, what's up, his perspective on all our new therapies for all these very challenging group of patients. So thanks for coming.
Pleasure to join you. Thanks.
Okay, the word of the day is Journal 2. Just a couple of announcements before Taha comes up here. At the upcoming Quad AI meeting on Sunday, I sent out an announcement, but if you haven't RSVP'd, we'll just have a social function as we've done in the past, which will self-fund. So I talked to a restaurant yesterday. I've made the arrangements. I just need to get a reasonably accurate head count. For the fellows, the good news is it's free to you. For the rest of us, we'll cover the bill, but I'll try and keep it at $50 or less a head. Otherwise, we're ready to go ahead. First, we'll have the Democratic memo, and then the Republican. Oh, no, that's CNN. Taha is going to go ahead. We've got a lot of material here, so we generally try and get through it pretty quickly and efficiently. We'll go first-year fellow, second-year fellow, faculty in that order.
Okay, good morning, everyone. So, today we're going to talk, first let me start by saying I have nothing to disclose. We're going to highlight key points on 2 recently published articles. And the first article that I'm going to discuss today is going over the efficacy and safety of birch pollen immunotherapy for local allergic rhinitis. An article by Bozic and his colleagues published on Annals of Allergy and Immunology in January 2018. So let me start by saying about local allergic rhinitis, and it's really underdiagnosed and undertreated. And the reason why, if you see about local allergic rhinitis, the symptoms of rhinitis, they should have a negative skin and serology, but they do have a positive nasal propagation testing. And this is how Quad AI actually define local allergic rhinitis. However, in the clinical practice, most of the time what we do is that patient presenting with rhinitis, we do the skin test, serology negative, we kind of assume it's non-allergic rhinitis. However, we treat them as non-allergic rhinitis. And the argument is that even if we know that this is local allergic rhinitis, there's really no more options for them other than the intranasal corticosteroids and intranasal antihistamine. So why do we bother by this? So in this article, we're looking for another option. This is allergy immunotherapy for patients with local allergic rhinitis. It's actually a randomized placebo-controlled study done in Poland. And what they did is they kind of screened over 79 patients. For the following inclusion criteria, they look on patients with well-documented symptoms of rhinitis during the birch pollen season. They must have a negative skin test, serology, and they must also be kind of negative for other allergens like dust mites, other seasonal allergens, and they're going to have a diagnosis of severe asthma or non-allergic rhinitis. And of those 79 patients, 29 patients actually met these criteria, and they randomized them to receive either birch pollen sublingual immunotherapy versus placebo.
Taha, did they look for nasal eosinophilia in these
No,
patients?
I didn't see, no. They looked actually for nasal-specific IgE.
Wouldn't you think that most of these we'd label non-allergic eosinophilic rhinitis?
That's what we.
I'm surprised they didn't look for nasal eosinophils.
I didn't see, though, even in the Quad AI, there is a category called like non-allergic eosinophilic rhinitis.
Mm-hmm.
Even the data behind the nasal like eosinophils is not so kind of specific for any diagnosis. You can find eosinophils without allergies as well.
Well, no, that's how you define it, exactly. Non-allergic eosinophilic rhinitis, and I think that most of us would probably diagnose this. Of course, we don't do nasal challenges, so you'd have to do a nasal challenge.
Yeah.
Okay.
And in those patients, actually, they were screened very carefully. They did like physical exam, they did nasal propagation testing. So the definition of their local allergic rhinitis was very specific. And they looked into this is the baseline characteristic, and as you may see here, there's really no difference among the two groups. What they did is that they followed those patients over a 3-year period. The first year was mainly a screening year, and then 2-year treatment. So the first year after they met all the inclusion criteria, which was negative skin test, negative serology, and positive nasal propagation testing, they asked them to fill a symptom medication score as well as rhinoconjunctivitis quality of life questionnaire. They also asked them. They also did some blood tests and nasal specific IgE as well. And then they followed before the beginning of the 2015 to randomize them. And then they kind of compared the result after 2 years for the symptom medication score and some secondary endpoints, which we will cover in the coming slides. So this is the primary outcome, and you see here that in terms of symptom medication score, they were able to achieve 65% reduction in symptom medication score, and this was a statistically significant result with a really very low p-value of 0.001. This is another way looking at the primary endpoints, and this is the weekly symptom medication score contrasted to the pollen count, and you can see that in the peak of the pollen count, there was really a huge difference in terms of symptom medication score between the treat activity group and the placebo group. This is looking at the average adjusted symptom score, which is well validated in allergy immunotherapy clinical trials, and you can see that there's huge statistically significant difference between the two. In terms of some secondary outcomes, looking on the right-hand side is the specific IgE to birch pollen, and you can see that the specific IgE went up within 4 months of treatments, and then goes down over the next 6 months back to baseline in the treatment group, as opposed to placebo, which it didn't change at all. Looking at the specific IgG4 to birch pollen, again, it went up, but it never goes back to baseline. And finally, again, with the nasal-specific IgE, on the left-hand side, you can see that the nasal-specific IgE actually went down with the treatments. And it was statistically significant in the second year. In terms of safety, there was really no systemic reactions during the entire study, so it kind of deemed to be safe, and the overall conclusion that it's efficacious and safe. A couple points was strengths and weaknesses of the study. You can see like it's they really kind of, those patients, like in terms of strength, is really very carefully selected. They even did nasal propagation. They did the nasal specific IgE. So they were really very kind of careful in selecting those patients. However, they did exclude non-allergic rhinitis, and majority of the time we see non-allergic rhinitis in combination with allergic rhinitis. So it's really hard to find those patients who are only monosensitized and they don't have other forms of rhinitis along with it. It's also a small study, and they have a deep reliance on nasal propagation testing, which something is not so practical in a clinical setting. So that's conclusion of the VAS article.
You know who funded it? I'm curious. I couldn't see any financial advantage to a pharmaceutical company.
I didn't look into the funding. It's actually all done in one practice, and maybe the sublingual immunotherapy people.
I was surprised at the percentage of patients that they identified that fulfilled their criteria. So I know that if in the past I've recruited for large hay fever studies from the community, and we've screened people, you get the occasional person who gives a very good history of seasonal rhinitis who has a negative skin prick test, but it's not common. And to find such a large number in the ones they screened, I'm surprised at that.
As Gary said, we see a fair number of people. Since we don't do provocation, we have no way of knowing.
No.
So we just call them eosinophilic non-allergic rhinitis. We've had that condition for as long as we've been practicing, and since we have no extra criteria to know that they actually have local sensitization, it's always been skeptical, does that condition really exist, or are these people just non-allergic?
Well, and I think almost all of these patients have nasal hyperresponsiveness. So again, they wouldn't qualify. I mean, I don't know how they found these patients. In other words, they have vasomotor kind of story.
Where was this done?
In Poland.
Huh?
Poland.
Poland?
Yes.
In mouse asthma models, there's evidence for local IgE production where you don't see it systemically. You can get actual plasma cell formation in germinal centers forming in the airways.
In this study, they actually documented the nasal-specific IgE to BAT-V1. So they really looked for the specific IgE, which was not existent. If it was not existent, they would never have been included. So there is a local IgE production that they proved in those patients.
The other thing that's impressive, I've been telling patients just anecdotally that conventional subcutaneous immunotherapy will make them 70% better. The published literature is nowhere near 70%. It's more like 30%. But here they had about a 70% improvement. It's sort of the first study I've ever seen to have really remarkable efficacy like you truly see in standard immunotherapy that we give people.
Okay, so let's discuss another article which is looking at safety and efficacy of immunotherapy with recombinant B-cell epitope-based grass pollen vaccine, or BM32. This is an article by Niederberg and his colleague, published at JACI 2018. So, and this is like looking at the strive to get a vaccine that is hypoallergenic or non-allergenic at all, and at the same time immunogenic, which in a way or another an equation very hard to achieve. So, in this kind of article discussing BM32, they were trying to achieve some sort of this balance. So, what's BM32? It's produced by peptide carrier fusion technology. So how did they make it? So they took this, this is the Timothy grass pollens, and they kind of isolated peptide, and this peptide is considered to be hypoallergenic. And why? Because this is the IgE binding site. This is where the IgE antibodies would bind, and this is considered the B cell epitope. This should not be recognized by T cell. So in a way or another, this should not elicit a Th2 response. However, it's not an absolute thing, but that's what they claim. And but because they lost the T cell epitope, it's not immunogenic. So what they did is that they kind of they fuse it with the free S protein of hepatitis B, and they create this carrier protein, and almost similar to what we see in pneumococcal conjugate vaccine. So this kind of serves that being hypoallergenic and at the same time immunogenic. And the way it will work, or that's how I understand it will work, is that this B cell will recognize one of the epitope on the grass, and once internalize it, will present the pre-S protein to T cell, and this T cell, because this pre-S protein will likely not induce Th2, will likely induce IgG production. So the end result will result in IgG4, and this IgG4 will be specific for the epitope, the grass pollen epitope. Hence, when the IgG4 will bind to this epitope and it block the IgE from binding. So it's more of producing blocking antibody. And this is a follow-up on phase 2 trial. And the nice about this vaccine, it can really be given only as 3 doses before the season, and that's it. So this is a double-blind, placebo-controlled trial, multi-center study in Europe, and they screened over 300 patients for the following inclusion criteria. They must have a positive history of grass pollen allergy, positive skin test to grass pollen extract, and they must have a positive immunocap as well, and moderate to severe symptoms of grass pollen. And from those 300 patients screened, they were able to select 181 patients, and they randomized them into 3 groups to receive either placebo or low dose of BM32 or high dose of BM32. These doses are based on what they found in the first phase 2 trial studies, and or placebo for sure. And looking at the baseline characteristics, again, if you have the glimpse look, it's a very busy slide, but all of them look almost the same. And they did the study over a 3-year period. 1 year is mainly for screening, and 2 year treatment period. So what they did, they bring them just before the grass pollen season, and they did a skin test, serology. Then they asked them to fill electronic diary, and at the end of the season, they again did repeat the skin and serology. And then before the beginning of the 2013, they randomized them to either of these 3 groups, and then they did again testing, skin testing, serology. They give the 3 doses of the vaccine, and then they did the same thing, electronic diary, and they repeat the testing, and they repeat the same all over 2014. There is an additional dose here given. This is probably just because some of the patient that has not been they didn't receive the 3 shots before the season, and they have to continue the 3 shots, so they give it after the season. And this is looking at the primary endpoint, which is the mean symptom medication score. And you can see they weren't able to achieve any statistically significant results. I just want to orient you about the three groups that they kind of compared to placebo, which is the BM32 pool, those any patient who received the vaccine, BM32 low, those patients who received the low dose of the vaccine, and they continue to be on the low dose. The BM32 high-low is subjects who received the high dose, and they later switched to low dose. And the reason why is that they did some interim analysis at the end of the first year of treatment, and they found that, and they thought like maybe the low dose is more efficacious. And the reason why they said like the low dose is more likely to promote affinity maturation of IgG4, hence probably enhancing efficacy. And that's why they switched all patients to low dose by the end of the first year of treatments. So far, no statistically significant. What they look into, however, they did they were trying to find another way to go around it. So they look into the baseline specific IgE and the percentage of reduction in symptom medication score, and they found that the higher the baseline specific IgE, the greater the reduction in the symptom medication score. So they did a post-hoc analysis looking into, again, the mean symptom medication score, and you can see they were able to achieve statistically significant results in the PM52 pool and the PM52 low-low. However, they couldn't achieve that with the high-low group. So this is, again, looking at some secondary endpoints, the rhinoconjunctivitis quality of life questionnaire, and you can see they were able to achieve some statistically significant reduction in a couple of these symptoms, mainly the nasal symptoms and the practical problems. In terms of other secondary endpoints, GRAS-specific IgE, and you can see, like, while it doesn't kind of blocks the IgE production, it kind of prevents the seasonally exacerbated rise in GRAS-specific IgE, which was statistically significant after the second year of treatments. In terms of GRAS-specific IgG1, and this is kind of maybe a little bit different from the regular allergy immunotherapy that also causes a rise in IgG1, you can see it actually goes up, but it goes back to baseline after treatment. And this has happened again the second year. This is not the case with IgG4, where it continues to go up and never goes back to baseline. And the investigator was even willing to evaluate the long-term efficacy of this vaccine. In terms of safety, they were, overall, the majority of reactions were local reactions, and they were more frequent in the treatment groups, but they were statistically significant. In terms of systemic reactions, there were systemic reactions again in the treatment group, which were more than the placebo group, but they never reached the grade 3 or 4. There's one autoimmune CNS disease that was kind of picked up during the first year of treatment, but that patients already reported some neurological symptoms prior to the start of the study. The second year, again, there's actually equal in terms of systemic reactions. They were almost the same, but there is like one severe reaction that has been reported in a patient who has asthma, underlying asthma. So overall, they said that the injection prior to season improved clinical symptoms of seasonal grass pollen allergy and were well tolerated. So the only thing that I found is, like, it's not like the first study looking at the regular conventional allergy immunotherapy, which was very effective. Like this one, they seems like a little bit more desperate trying to find statistically significant result. But it's a good try to find like a vaccine that is really safer technically because it's not allergenic and can be used in patients probably with uncontrolled asthma. And at the same time, it's also more convenient. It needs to be only administered 3 times prior to the season, and that's it.
The only problem is it didn't work. People have been trying to do this for 50 years, and I mean, it's interesting, just conventional empiric immunotherapy, the way we've been doing it, no one's gotten a better system than that in 50 years. Almost every attempt to do something to modify it has been a failure, in my estimation. But
they have like they have some positive results, but I think it's a good try to find a vaccine that is because it didn't cause any rise in specific IgE. It actually only blunted the rise in specific IgE. So those patients, because most of the time this rise can cause trouble like asthma exacerbation. This would not be the case, and also in terms of like convenience. We give the vaccine over 3 to 5 year periods and lots of injection. This is only 3 injections prior to the season. They can play with it probably a little bit to kind of tweak it a little bit to make it even better. However, it does rely on blocking antibody as opposed to promoting T regulatory cells, which we will see with conventional immunotherapy.
It just has to be significantly more efficacious to ever be a marketed product.
I think Mark Larcher in Barry Kay had a peptide vaccine with Circassia, and I think that was abandoned after a while. It wasn't that effective.
Because most of the time they were isolating a T cell epitope, and once you get the T cell epitope, you'll end up with Th2 response. So, kind of argues that this one is only B cell epitope, so it should not get any Th2 response. There may be some Th2 response, but not as dramatic, because this is the peptide only recognized by B cell. Even if it's internalized and presented by B cells, it should not elicit a T cell response. The T cell response relies mainly on the VAS protein from the hepatitis B. So in this way, they were trying to ensure immunogenicity, yet at the same time maintaining the hypoallergenicity of the vaccine. I mean, in the phase 2, they didn't say it's hypoallergenic. They said it's non-allergenic. In the phase 3, they said it's hypoallergenic because they know that there may be some Th2 response. Interestingly enough, actually, it blocks hepatitis B infection also in vitro.
Taha, do you make your own slides?
Yes, I do.
These are phenomenal.
Yeah, you do
All
a
the
fantastic
techniques.
job in,
I need some
presenting.
help with my presentation.
That's what I was thinking.
Yeah.
Maybe Taha can help me with mine.
All right, let's change speakers. Jay?
That's right.
Alrighty.
Drew just pointed out to me that I think the first paper you're going to do is from Param Nair's group up in
Yes.
McMaster. He'll be here in about a month or so, so he can speak for himself.
All right, so then I'll skip that one. So I don't have any disclosure that's up. I don't think my slides are as exciting as the previous one. But so the first paper I'm going to talk about is weight-adjusted IV ruxolitinib in severe asthma with inadequate response to fixed dose subcutaneous mepolizumab. So it's a paper from Dr. Nair's group from Ontario, Canada, at McMaster, and they had an open-label mepolizumab study which they recruited 10 patients from with severe asthma. So the objective of the study was to look at clinical and cellular outcomes in patients with prednisone-dependent asthma, and looking at both mepolizumab and ruxolitinib, but also with the thought that there may be a subpopulation of these patients that benefit from weight-adjusted intravenous dosing with the suboptimal response to this subcutaneous dosing of anti-IL-5 monoclonal antibody. And so their hypothesis was the patients with the starting ruxolitinib would be effective in severe prednisone-dependent asthma, and that higher doses of the medication would be more effective to control airway eosinophilia, and this would be associated with improved outcomes. So the inclusion criteria was patients with prednisone-dependent eosinophilic asthma. So this was they did looked at FEV1 reversibility greater than 12% or a methacholine challenge, and also so that in addition to persistent eosinophilia despite maintenance steroids. And these patients had been participating in an open-label clinical trial of mepolizumab. So when I talk about the study design, these patients were compared to historically how they did on mepolizumab. So, and then they were 18 to 75, and they had to have either sputum eosinophils greater than 3% or a blood eosinophil count of greater than 300 on the first visit and after the 1-year washout period. And these are some of the exclusion criteria. And so study design here. So they had invited 13 patients to from their open-label mepolizumab study to participate. So this is the phase 1 is that open-label mepolizumab study. So from here, the 13 patients had all participated in this, and that's what's being used to compare to the patients who these patients who then had a 12-month washout period, and then 2 months of placebo, and then started ruxolitinib. So of the 13 patients, 10 actually went through with the study, and then so they had different ways of comparing. First, the mepolizumab baseline, and then the end of treatment. So prior to treatment with mepolizumab, and then also with ruxolitinib baseline after the washout period, then at a time point of after receiving placebo, and then finally after treatment with 4 months of ruxolitinib. So there's a couple different things. So it was 12 months of mepolizumab versus 4 months of the ruxolitinib. They compared a couple different time points. So the primary outcome, they were looking for a reduction in blood and sputum eosinophil count, and they looked at other secondary outcomes, so a change in FEV1, an asthma control questionnaire of 5 questions, eosinophil peroxidase, and these are other secondary outcomes, eosinophil peroxidase, IL-5. They also looked at eosinophil progenitor cells and then sputum and blood innate lymphoid cells. That could be an important source of IL-5, and they looked at this using flow cytometry. These are the demographics. So looking at so these are all the same patients, but just looking at their different pre-trial intervention characteristics. So they were pretty comparable, except the FEV1 to start with in the ruxolitinib group. These patients had a better FEV1, and it could be that they had been on mepolizumab for 1 year and had some benefit, and that's why there was a significant difference prior to starting either of these therapies. But otherwise, the rest of them are a little comparable. The sputum eosinophil percent was actually higher in the ruxolitinib group. This is prior to starting, but again, it was not significant. Same with the blood eosinophil count. So these patients had been treated with mepolizumab, had gotten a little bit better, but after the washout period, had both blood and sputum eosinophilia. So here's the primary outcome results. So it's a little bit of a complicated slide, but here is the looking at sputum eosinophils, and here are the blood eosinophils. So the sputum eosinophil percentage, there was no significant difference in mepolizumab in these 10 patients, but there was a significant difference post ruxolitinib, which is different than the blood eosinophil counts, which the post-mepolizumab and post-ruxolitinib, they both had a suppression of blood eosinophilia. But here, there wasn't a significant change in the sputum eosinophilia. And then post-ruxolitinib, there was a change from baseline and the placebo compared to after treatment with ruxolitinib. So, and then looking at the FEV1 and the ACQ scores. So, again, here there was a improvement in FEV1 with after mepolizumab from baseline, and then there was an improvement looking amongst both baseline and baseline and placebo to ruxolitinib, but there was not a significant difference amongst the between the two groups in terms of FEV1. And then there was a significant difference in asthma, the asthma control questionnaire, with a higher score, meaning less control, and they asked 5 different questions for that. So conclusions of the study. So I thought 4 doses. Things I could take away from it was that 4 doses of IV ruxolitinib are effective in suppressing sputum and blood eosinophilia in this selected group of patients with severe prednisone-dependent asthma. And the treatment effect was greater with IV versus subcutaneous mepolizumab, and it could be that it was a reflection of giving it intravenously and it's weight-based dosing, and that especially in regards to airway eosinophilia, there hadn't been a significant difference in FEV1, but in terms of the sputum eosinophilia and the asthma control scores. So I think, and this was only over 4 months, so it'd be nicer to see over 12 months or longer to see how these patients would have done. And then also the sample size of this population, it's only 10 patients, and also the design of the study, they were looking after they had the washout period, and they had given a placebo versus a randomized controlled trial to compare 2 different treatment groups. And then the blood eosinophil, there was suppression of blood eosinophilia in both populations, but specifically there was the sputum eosinophilia was not suppressed in the after mepolizumab in these patients. Any questions?
Well, Param's almost the only person who can do this because he's really the only person who does sputum eosinophilia like doing a CBC as just a part of routine analysis. So it's going to be hard for anybody else to reproduce it. But and he seems to be the only person that I know of who has amazingly severe, hundreds of amazingly severe asthmatics. I mean, do any of us have these kind of patients in large numbers? No. But he's an incredible guy, so I certainly trust his results.
Well, the BMI of this group of 10 patients, was that high relative to
the what?
The body mass index? Anything unusual, peculiar about this group, or that they'd be?
I don't remember. I don't think they gave BMI.
And did they track exacerbations? That's typical.
Not that that might have been in like supplementary data. I'm not sure.
How about their prednisone use? Are they prednisone dependent?
We'll have to come back on that.
A few comments I would think is relevant to make. I think, as we move into an era where we've got newer biologics coming forward and we've got more, it's obviously going to be very important to try and understand, how you select patients and which patients are right for which one and whether there's any differences between them. But sadly, I don't think this particular publication really helps from that point of view, because a few things that are not really revealed in the paper. It's presented as a phase 1 and phase 2 as if it's a sort of an organized thing. In fact, that 1 year of mepolizumab treatment was a follow-on safety study after patients had already been on mepolizumab or placebo. And so what it's comparing is mepolizumab-treated patients on entry with 1 year later whether mepolizumab has improved them. And so when you say, that there's a bigger improvement later on with reslizumab, you're actually not treating untreated patients. You've got patients who come in from a study that was the Sirius study, which then went straight on into a study called the Cosmos study as a longer-term follow-up study, which actually showed that once you improved on mepolizumab, that improvement was maintained. And so that 1 year is taking patients. Some of those patients would have been on placebo, but from that centre, the majority of them were on active treatment. So you're taking already treated patients and then looking to see what happens to them. And then later on, when they were off all that treatment for a period of time, they had more eosinophilic inflammation, both in blood and sputum, lower dose of steroids, and then you report that they get a bigger improvement. And what we do know from all the studies that have been carried out is the more eosinophilic you are, the greater your response to treatment. And so if you then take that group, it's hardly surprising that they do well with that. So scientifically, one can't really understand how that was accepted, but I imagine that you get a lot of references, and so it'll do well for the impact factor.
Jay, can you just go back to the demographic slide?
Yeah.
So I think, so these are the data that we're seeing is before starting drug, M or MRR.
Mm-hmm.
So to your point, you can see the EOs were actually higher when you started res, and actually the FEV1 was worse. Yes. So they had sort of more to gain.
Yeah, and you know, it says it's not statistically different, but then you haven't really got power to show that.
No.
You've got smaller numbers.
Just as an aside, too, I just was reading something from Brian Lipworth, noting that the res of Q failed. It was just reported. And in other words, their products of Q actually did not show it better than placebo.
What, subcutaneously? Oh, right.
At 100,
right.
same dose as mepolizumab. Right. So that was intriguing.
Yes, yes. Yeah, no, Parham, you know, I got great respect for him, but I don't think this is one of his best publications. but he's got this idea that it's only blood sputum eosinophils that determine whether you're eosinophilic or not. And, you know, that's one way of defining it. But certainly in the program with mepolizumab, blood eosinophils have come out as the best indicator of a beneficial response. And probably is influenced by your peripheral airway inflammation as well as your central airway inflammation, where sputum telling us about what's happening within the central airways.
Well, I don't want to stifle conversation, but I want to let you move on.
So I'll quickly go through this one. So this was a multi-center trial done in Europe with looking at mepolizumab and reducing the need for surgery in patients with severe rhinosinusitis with nasal polyps. So just to introduce, patients with chronic rhinosinusitis with nasal polyps have a high recurrence rate after surgery. So their goal was to look at the safety and efficacy of mepolizumab, and this was IV mepolizumab, 750 milligrams intravenous, versus placebo for severe bilateral nasal polyposis. And their hypothesis was that it could reduce the need for surgery in these severe patients. So the study design was a randomized controlled placebo-controlled study that, and it was multi-center. They had 6 centers in 3 countries, Belgium, Netherlands, and the UK, and it went on from 2009 to 2014. So that they were looking at treatment group of mepolizumab, 750 milligrams IV every 4 weeks for 6 doses, and these patients were on intranasal steroids versus an IV infusion of placebo plus intranasal steroids. So the inclusion criteria, patients were 18 to 70, and they had severe bilateral nasal polyposis, and that was defined by a visual analog symptom score of greater than 7, and endoscopic polyp score of 3 or more in one nostril and then 2 or more in the other nostril. And this had been refractory to use of intranasal steroids or a short course of oral steroids. And exclusion criteria was continuous use of high-dose oral steroids, other biologic medications, or asthma exacerbation, requiring hospitalizations within the 4 weeks of screening. And the primary endpoint were patients who no longer met the criteria for requiring surgery after the final dose, and that was going back to the endoscopic polyp score of greater than 3 or more in one nostril, and then 2 or more in the other. So, and then also a VAS score of greater than 7. So the patients who did not have this criteria anymore, they were looking at to see if there was a difference in placebo versus the treatment groups. And then secondary endpoints were changes in the VAS scores, and they did these VAS scores for multiple different symptoms, including rhinorrhea, mucus in the throat, change in the nasal polyp score, improvement in the symptoms, so rhinorrhea, mucus in the throat, nasal blockage and smell, and then safety and patient-reported outcomes. So here they screened 109 people, and then 107 were randomized. So about 53 in placebo and 54 in mepolizumab, and they had a pretty high discontinuation rate. So 33% on placebo and 22% in the mepolizumab group. So looking at the results, so here looking at their primary outcome in terms of percent of patients in need of surgery, both groups were 100% prior to starting. They said there was a significant difference in the means of these groups, but the 95% confidence intervals were not statistically significant. And then the adjusted mean VAS scores, and there's a breakdown on the following slide of the different ones. That was also statistically significant, and that was as noted as early on as 9 weeks. And there was a decrease in both placebo and the treatment group, but both groups were getting the intranasal steroids. So it may have been a reflection of the use of the intranasal steroids. So this is breaking it apart into the different the different VAS scores that they looked at. So rhinorrhea, mucus in the throat, nasal blockage, and the loss of smell. So they saw improvement in the mepolizumab group versus placebo in all these outcomes. And then looking to see if they could look at baseline eosinophil count to see if there was a difference between these patients who responded versus did not at week 25. So they didn't see really a difference in pre-treatment eosinophil scores. So and of note, there were some patients with blood eosinophil counts that were close to 0. So, but the mean was around about 500. And then looking at the post-treatment SNOT-22, which is a questionnaire of symptom scores. So that looking at their baseline, so it was comparable to in both placebo and the mepolizumab groups, and there was a change after treatment in a decrease in both, but mepolizumab had a statistically significant decrease versus placebo. So just to sum up, the patients in the mepolizumab group did have a decreased need for surgery, which was their primary outcome, but there was improvement in the placebo group as well. And the dosing used was different than we typically use here as a 750 milligram intravenous dosing. And there was no difference in, you can't really use eosinophil, at least this study showed that it was harder to use pre-testing eosinophil counts to try to predict which patients would respond better. And if the patients do respond, a difference was noted as early as week 9 of therapy.
Is 750 IV an approved usage in Europe?
No, you saw that study started in 2009. That was part of the mepolizumab development program, and this was a sort of proof of concept study. So there is a program going on now with Nucala looking at recurrent nasal polyposis to see whether treatment can prevent the need for further surgery.
But it's not currently approved that way.
No, there's no approval for that. It's in the trial stages at the moment, so it's not a licensed indication.
Are they studying patients that sort of on the other end? In other words, I just had surgery. In other words, preventatively. No. I suppose one has to have some health economic outcome to justify the treatment, and so the need for surgery is what the outcome is. But obviously that would be a logical consideration. Yeah.
It was just polyps.
I want to make sure we leave enough time for our last speaker.
I believe they were not AGRD patients.
Go ahead, Lahari.
I love biologics and peptides. I'm going to talk about macrolides. Something simpler. So we know
know that there is stronger evidence in COPD, usage of azithromycin in COPD, but there haven't been a lot of studies looking at the effect of macrolides in asthma. That's why I decided to choose this, because any add-on treatment in our patients with uncontrolled asthma, which can improve quality of life and the exacerbations, is important to be considered. Nothing to disclose. So we're going to talk about a case. This is a 58-year-old female with past medical history of hypertension, GERD, chronic rhinitis, and asthma. Was referred to an allergist for uncontrolled asthma with frequent exacerbations and daily symptoms, despite LABA, ICS, LAMA, and singular. Her environmental allergy testing came back negative, and her IgE is 35. Eosinophil count is 150. Off prednisone and PFT shows reversible bronchial obstruction. CT chest is unremarkable, and she's on an optimum medical regimen, as you can see. And what would you consider as your next option? Referral for bronchoscopy. Any of you do that? Referral for bronchial thermoplasty and biologic therapy. Of course, that's the next option. But it can be expensive, and many patients do not meet the criteria, and some of them cannot access it because they live far away. And the other option is the trial of long-term macrolide prophylactic therapy.
What about just a burst of prednisone?
I would choose 4 because that's my topic today. So this is the article I'm going to present, the effect of azithromycin on asthma exacerbations and quality of life in adults with persistent uncontrolled asthma. This is a randomized double-blind placebo-controlled trial. This was considered as the landmark article published in The Lancet in August 2017 by Dr. Gibson and colleagues in Australia. So as we all know that macrolides have anti-inflammatory, antiviral, and antibacterial role in both eosinophilic and non-eosinophilic asthma, according to several studies. But the study results have been inconsistent previously. Their effect on asthma exacerbations have not been very clear, or for any phenotype-specific effects. And systematic reviews were not able to draw conclusions because the data was not, because of the lack of data, the study results were heterogeneous, and because of the inadequate study designs. One of the major studies which looked at this, the effect of azithromycin on exacerbations, was published in British Medical Journals in 2013. That was also a multi-center randomized double-blind placebo-controlled trial. But I'm going to discuss about this study in the discussion after I finish this study. So as I said, this is an RCT. So they looked at the efficacy and safety of oral azithromycin, 500 milligrams 3 times per week for 48 weeks in patients with persistent symptomatic asthma despite ICS and a long-acting bronchodilator. Eligibility criteria was they included patients above 18. I'm sorry, I didn't mention that here. And asthma with variable airflow obstruction and reversibility of at least 12%. An increased peak flow variability of more than 12% over at least 1 week of monitoring. And the patient had to be symptomatic with at least partial loss of asthma control with the ACQ-6 score of more than 0.75 despite ICS and long-acting bronchodilators. The patients had to be clinically stable with no recent exacerbations or infections or any changes in maintenance treatment for at least 4 weeks before the study entry. And they had to be non-smokers, and they confirmed it by exhaled carbon monoxide. The smoking affects inflammation of the airway, and that's why they excluded the smokers. A little bit on the study design and randomization. And they randomized the patients according to a computer-generated random numbers, and all investigators, the research staff, and doctors were masked for treatment allocation, and the patients were treated for 48 weeks, and they regularly assess the patients at regular intervals. It's interesting that they phenotype the patient. If a patient had more than 2 severe exacerbations in the past 12 months, they group them as exacerbation phenotype. And if their sputum eosinophils were less than 3% and blood eosinophils of less than 300, they were non-eosinophilic. And if this was more than 3% and more than 300, eosinophilic group. At each visit, they looked at ACQ-6 score, medication use, asthma exacerbations, adherence, and adverse events, any self-reported respiratory infections, and spirometry. They also did telephone assessments. Their induced sputum was also collected at randomization and end of the treatment. And for safety monitoring, they looked at LFT, EKG after 6 weeks and at the end of the treatment. And if they had QT prolongation of more than 480 milliseconds, they withdrew the patients from the trial. And they also did microbiological assessments, including sputum culture for any pulmonary pathogens. They did throat and nose swab cultures at randomization and end of the treatment. The primary outcome was that the total number of asthma exacerbations, severe and moderate, over the 48 weeks, and asthma quality of life. And the secondary outcomes were ACQ-6 score, lung function, induced sputum cell counts, antibiotic courses for respiratory infections, and microbiological assessments for resistance and also adverse events. So they totally screened 582 patients, and 162 were excluded, and mostly because their inclusion criteria was not met. And 420 patients were randomly assigned, 213 in azithromycin group and 207 in placebo group. 45 patients, around 40 patients were withdrawn on both sites because of various reasons, and 168 completed the treatment, azithromycin treatment, and 166 the placebo group. They analyzed all patients for intention to treatment. So I would like you to look at the characteristics table. I didn't include that because it's too big and it's too busy. It's right in front of you. This one. If you look at the age groups in placebo and azithromycin group, they were around 60 years of age, and around more than 80% patients were atopic. And the asthma, most patients had asthma for a number of years, and it's interesting that they didn't have a lot of exacerbations in the previous year. They had one unscheduled visit and one steroid course on an average on both sides. And in terms of medications, most of the patients, more than 80% of the patients were on high-dose steroids, and more than 90% were on long-acting bronchodilators, and around 3% on oral steroids and other medications. Their FEV1 was around 70% on both sides. If you look at the sputum counts and the sputum phenotype, patients in placebo group had a little more eosinophil percent and absolute numbers compared to the azithromycin group, including the blood eosinophil was a little higher in the placebo group. Coming back to the results, this picture is looking at the cumulative severe and moderate asthma exacerbation. As you can see, the patients on azithromycin group had significantly reduced asthma exacerbation. It was 1.86 in azithromycin and 1.07 in placebo group. This figure looks at the exacerbations per year and incident rate ratio. Incident rate ratio is not the same as incidence. Incidence is the number of new patients divided by the population at risk, but incidence rate ratio looks at the takes into account the time period. So they are looking at the incident rate ratio in exposed versus unexposed, which was reduced by the azithromycin group. Here we are looking at the proportion of patients free from an asthma exacerbation for 1 year, according to the treatment group, and they are looking at the median exacerbation-free days, which was higher in azithromycin. It was 344 days and 148 days in placebo group. And here we are looking at the effect of azithromycin and asthma exacerbations in both eosinophilic and non-eosinophilic asthma. It looks like the azithromycin reduced exacerbations in both phenotypes, that you can see here. This was the other primary outcome. This is the effect of treatment on asthma-related quality of life. And when you look at the AQLQ symptom domain before randomization and end of the treatment and change from randomization, that was significantly improved in azithromycin group. This is again looking at the primary outcomes, and these are the various secondary outcomes. This slide is busy, but what it showed was that the ACQ-6 score significantly improved in azithromycin group, and FEV1 didn't change much. It wasn't significant. But they also looked at other symptoms, including nasal symptoms, breathlessness, wheeze, and sputum production and cough. What significantly reduced was that the nasal symptoms significantly reduced. The number of patients with cough at the end of the treatment also reduced, and the sputum production. They also looked at the cumulative antibiotic-treated respiratory infections during 48 weeks of treatment. They noted that azithromycin significantly reduced the antibiotic-treated respiratory infections. Coming to adverse events, in this slide we see the serious adverse events, which wasn't very different in placebo or azithromycin group overall, but it's important to note that antibiotic-treated respiratory infections were significantly lower in patients who were on azithromycin. Coming to the treatment-related adverse events, as you can note that gastrointestinal side effects were higher in azithromycin, especially diarrhea, which was more in the azithromycin treatment group. They did not find a significant difference in terms of headache and vertigo, hearing loss, or abnormal liver function test, oral thrush, allergy, or rash. But they noted that QT prolongation was, they noted that a higher number of patients had QT prolongation, slightly elevated number in azithromycin group. I feel that some of the slides were missed for some reason. It's not. When I went to the slideshow, these slides were skipped for some reason. Realizing that. Just wanted to briefly tell you about the exclusion criteria. Any patient who had a substantial parenchymal lung disease were excluded from the study, and they also excluded ex-smokers with more than 10 pack years of smoking if the DLCO was less than 70%, and also with patients any hearing impairment or QT prolongation, because azithromycin is known to cause these side effects.
I think you need to go to the discussion
Yes.
anyway to wrap it up.
So there are only a few studies which looked at the effect of macrolides on asthma exacerbation. And going back to the study that I mentioned, this was published in British Medical Journal in 2013. That was called the AZISAS study. They used a lower dose, which was 250 milligrams 3 times per week for 26 weeks. They also had lower number of patients, and this study was also an RCT. They did not find any reduction in asthma exacerbations overall, but in a subgroup analysis, they found that in patients with non-eosinophilic asthma, the severe asthma exacerbation was reduced, and they also noted lower number of respiratory tract infections. In AZISAS study, they had patients with frequent exacerbations compared to the current study that we discussed, and they also had frequent respiratory tract infections, but their eosinophil count was less than 0.2, which is less specific for eosinophilic asthma anyways. In the current study, which is the AMAZES study, they noted reduced exacerbations in both eosinophilic and non-eosinophilic asthma, and they looked at the composite endpoints, which was reduced severe asthma exacerbations and respiratory tract infections, or both. And they also noted reduced respiratory tract infections, which is consistent with the SSS study. There was another study using 600 milligrams of weekly azithromycin for 12 weeks, but they did not find any difference in exacerbation frequency. So if you're actually looking at azithromycin, it's well tolerated, with only diarrhea being a little more common in patients who were treated. And they did not find excess withdrawal because of diarrhea. They did find increased resistant organisms, but it wasn't statistically significant. And microbial resistance is obviously a concern for long-term usage. So in conclusion, azithromycin 500 milligrams for 48 weeks did reduce exacerbations and improve quality of life and reduce respiratory tract infections. And oral steroids have long-term side effects, as we all know. And biologic treatments can be expensive, and some patients do not meet the criteria. And monoclonal antibodies are mainly used in patients with frequent exacerbations. And they claim in this study that azithromycin has almost similar efficacy to monoclonal antibodies. Pardon, Dr. Howard. You'll be talking about biologics. Azithromycin has a broader benefit in patients even without a history of frequent exacerbations. And it should be considered in patients who do not meet the criteria for monoclonal antibodies or even before starting biologics.
Did they measure the effects of the metabolism of the steroids in the patients that were on azithromycin versus the ones that were not?
No, they didn't.
So is this the same thing as talmedrol that we had 35 years ago? Is that it just changed the metabolism of steroids?
Just 35 years ago.
Back when you were born.
Yeah. There was a macrolide, what's the full name of it? Which was said to be efficacious in asthma. And those were in steroid-dependent patients, and what was ultimately learned is it just changed the metabolism of corticosteroids to lengthen the half-life of the steroid, and it didn't really have any inherent effect as a drug itself. They didn't
but
look at
azithromycin, it has some inherent effects on IL-5 and antimicrobial, antiviral, and somebody was also commenting that it affects motilin. It has agonistic effects on motilin, which decreases reflux symptoms in asthma patients. That's one of the major causes for cough and sputum production and even symptoms in uncontrolled asthma.
Perhaps I could comment about the efficacy in comparison to biologics. All the biologic studies really focused on oral steroid requiring exacerbations. That's how they defined exacerbations. This study, as you see, lumps what are called moderate and severe exacerbations together. They actually documented severe exacerbations but didn't report them. So one has to assume that there wasn't an impact on oral steroid requiring exacerbations. And moderate exacerbations had a number of different definitions, but it could be as little as an increase in beta agonist use for 2 days. And so, to say that the outcome with these is the same as with biologics, because you get a 50% reduction in how they defined exacerbations, it is misleading, really. But obviously, the interesting thing here was that the previous, best study with G. Bruxelles had just identified no effect on exacerbations, but a possible effect in a neutrophilic subset, whereas this has suggested that there's a benefit in improving, I suppose, what one would say, control, really, if the majority of the effect is on the moderate exacerbations, which are just beta agonist use or lung-function changes.
Did they actually look like for chlamydia and mycoplasma and these? Because years ago there was thought that maybe they were causative or they had chronic infection with those organisms. Did they comment on those organisms?
I don't think they commented.
Did they culture it? Did they look for it?
I don't think they looked for it, but they looked for significant respiratory pathogens.
Yeah, they did some simple sputum culture.
Yes.
But my understanding was that they were probably also going to do a microbiome analysis, which would probably be more revealing from that point of view. But I haven't seen anything published on that.
There's got to be some use for for macrolides. I mean, even in the pediatric population, there's, I think Fernando Martinez published some data in 2015 looking at azithromycin at the onset of a URI in preschool children, and found, did you see that? Yeah.
Yes.
And found that, you know, they had a significant reduction of lower respiratory tract infections. So, I don't know. Yeah, I haven't done it in practice, and this was just adding azithromycin, nothing else. And a lot of these kids
used it
had
in
asthma.
COPD patients while I was in residency, but now I will consider azithromycin in asthma patients, especially have a severe disease burden or not having really exacerbations, but at least daily symptoms.
Right.
And patients who are far away and not meeting the criteria for biologics and have insurance issues and things like that, I think it's not a bad thing to consider azithromycin.
So if you're going to do this, do you have to do an EKG and a hearing test first?
Yes, I mean, azithromycin did not significantly increase the hearing problems as opposed to the study in COPD and NEGM in 2011. This study did not find significant difference, only slightly higher compared to placebo group. But diarrhea was more common.
In the asthma
But
group,
EKG should
they are
be
younger.
considered.
They are younger, less heart disease, like I was opposed to COPD. They're all 60 and above.
Now this patient is, most patients were around 60 years old in the study.
Well, let's just segue to next week's speaker, who's our audiologist, talking about common hearing problems. And you can ask him the same question. All right, thank you. We've got a break.
That would be interesting to know for a check like nasal hyper response. In other words, how much of it is just preventing infection or infection. You know what I mean? Or is it really?
It's in the bed situation right now, so we can't promise like a specific date. But he said we should sort of get
Always come up with
I'm planning, I might just more than
So I talked to the PE chief yesterday. They said that the bed situation is pretty tight right now. So they can't promise a specific date, but they can probably fit it in for sometime. So I called mom. She said that that was fine. She was amenable as long as we give her a couple days notice. So the PE chief said we should plan on talking again on Friday once we have everything set up for and we know what we're going to do. We're sure we want to admit. And then
As long as there is an opening.
yeah, and then they would on Friday let us know what day. What day would be better, and then I can let mom know once we have like a actual date. They don't promise mom anything right now. They don't know exactly.
I mean, and then
So it sounds like maybe choosing for your
No.
She said she didn't.
for us to
I have a chemical call. I have to sit and work on it. The exact doses.
We're going to go to the conference room, don't we?
Okay. And send you the Word document.
So I don't know whether...
Yeah.
Testing. Some of them.
Yeah, well, obviously that would change how we approach it, right?
Yeah, I know.
extensive
They train
testing
like
in the south.
I think
So
there's
this is like, so this is, it sounds like.
Yeah, we've got
Flushing,
faculty,
mom says,
community
lethargy, and sometimes dairy, but what about the vomiting?
They're all small programs,
Yeah.
but they have one or two
Vomiting,
each.
but it's not
And then, so then all of a sudden you have 12 or 13.
So
Yeah,
cool, then
exactly.
I think our endpoint for this.
So, yeah, and
Mission is
then
at least 3 foods introduced.
Oh, yeah.
Oh,
Kids
yeah.
doing
Yeah,
fine,
that's
maybe
like,
alleviating
the
anxiety.
trainer and
also
stuff.
looking at the kid,
Of course, do you need to get at your taste level during an episode?